crippling fistulas with which the patient's life becomes difficult. And it's 32% in surgical step-up versus the 5% in endoscopy, as published in the famous landmark trial in the Lancet 2018, which is famously known as the tension trial. Here we can clearly see that surgery creates complications while endoscopy protects them. Now, escalating the evidence further, endoscopy not only eliminates or reduces the fistula rate, newer evidence has shown that the fistula rate with the transluminal endoscopy is essentially zero. It has not reduced, it has eliminated the crippling fistulas. Let's talk about something which surgery takes a toll on patients' morbid conditions and life. One is the systemic impact. Surgery has a huge systemic impact. The systemic impact in the surgery can be depicted, can be seen by this slide. The organ failure in surgery is almost double as compared to endoscopy. And this includes both single organ failure and multiple organ failure. This same can be replicated with other complications like bleeding, which is in the range of 5 to 20% in the surgery, as opposed to 0 to 5% in endoscopy. So a big question that we have talked about morbidity. Now a big question is it's all surgeons ask is that okay, morbidity is okay, endoscopy reduces morbidity, but does it reduce mortality? Does it save life? And there is a clear-cut answer: yes, it does, as evidenced by various trials and meta-analysis, which is published in well-reputed journals like AJG and Endoscopic International. A key point about the reality, the cost. So what about the cost? Endoscopy has a clear advantage as compared to surgery in terms of length of hospital stay, cost, and in terms of quality of life. These indicators clearly demonstrate that surgery is a financial liability in modern times. Most of the times, our surgery colleagues were or had the apprehension that okay, you have a less morbidity with endoscopy, you have a less mortality with endoscopy. But what about lateral collections? Can you reach there? You have access through the gut wall, but can you reach the lateral collection? We didn't have the answer to this problem till some time back, but now we have an answer for this as well. This concept is now outdated, and we have an answer in the form of PEN. PEN has solved it. PEN is percutaneous endoscopic necrosectomy. So PEN has a success rate of 82% with 0% mortality. And this can be done under conscious sedation, solid, we can remove the solid necrosis. So essentially with PEN, we can reach, we can clear, and we can repeat the procedure. Endoscopy is not a technique, it's a single complete paradigm. It has zero incisions, and this one algorithm completes it all. Whether you have central collections, whether you have lateral collections, or whether you have complex collections, all can be tackled by endoscopy without incision. So I will not take much time. The data has finally spoken, and I will just enumerate that surgery has higher fistula rates, it has higher systemic insult, it has higher cost, higher mortality, while endoscopy guides precision, has protection, and is flexible. So the question is not whether endoscopy should be done or not, whether necrosectomy and fluid collection should be treated with endoscopy or not. The question is, when we have endoscopy, why should we choose anything else? And with this, I conclude and leave it to my surgical colleague to say about the surgical part. Thank you.
Thank you, Dr. Tahir. Now, Dr. Sahil will talk on the role of surgery for ball duct necrosis.
Good evening, Chairpersons. First of all, I would like to thank the organizing team for giving this opportunity. So, my part is to defend this surgical management pancreatic necrosectomy. So, actually, out of the 100 patients which develop who develop pancreatitis, it is a 10 to 20% who actually develop necrosis, and out of them, it's a 30% which develop this infected necrosis, and they are associated with high morbidity and mortality despite modern ICU care. Historically, early open necrosectomy was the standard of care, but it carried major complications, whether it's a fistula or organ failure, driving this field towards delayed minimal invasive and step-up approach. Today, we have different options available for managing this pancreatic necrosis in the form of whether it's endoscopic or minimal invasive surgical, in the form of whether it's a percutaneous or ward and laparoscopic are ultimately open. So, debate is not about whether we should be minimal invasive, which I think we all agree, but how far the endoscopic first dogma can be safely stretched before surgery becomes indispensable. So everything has to be backed by the data. Dr. Tahir has already discussed about some of the literature. So high quality RCTs shows no the survival advantages as the mortality is concerned. Whether it's a tension trial, Bang et al., and many of the meta-analysis shows that there is no mortality advantages, though it has some advantages in the form of few fistula rate and hospital stay. But as if we dissect this literature, we will see these are mostly done in high volume centers where the expertise is available. Even the long-term studies like extension trial and Timmerman et al. Say that there is no difference in terms of mortality, and there is no significant difference in pancreatic functions. So I can say that endoscopy and surgical step-up strategies deliver similar hard outcomes. These data argue for multidisciplinary step-up model, not shutting down the surgical arm of the care, especially for the anatomically complex and unstable patients. So, Dr. Tahir has already discussed that we can reach this previously used to be thought of unreachable areas, but endoscopies are mostly favored for centrally located liquefied necrosis that too in close association with the you can say whether they are abutting the stomach or duodenum. For deep multi-loculated lateral pelvic collections, still only surgical approaches are preferred, whether it's a percutaneous followed by ward or laparoscopy or open. So, in real life, the sickest persons, they are not saved by the endoscope only. They are actually saved on the OT tables. As far as there is clear-cut indication where endoscopy have no role, like patients with bowel ischemia, perforation, abdominal compartment syndrome, or uncontrolled hemorrhage, and other emergencies like pseudoaneurysm rupture, generalized peritonitis. So, in terms of quality and completion of debridement, large transgastric series shows operative transgastric necrosectomy often resolves collection in a one procedure, where usually endoscopic procedure needs repeated necrosectomy. Endoscopists need to go in after 20 to 48 hours to check for the hemostasis or completion of the necrosis. So, and surgical approaches also have a advantage of having a direct wide exposure and controlled hemostasis. So, so I can say that real comparison today is not this endoscopic versus open surgery, but open surgery versus minimal invasive surgery. Once you modernize the surgery, its outcomes fit in the same range as advanced endoscopy while keeping the options of definitive debridement. So a pooled analysis of 1980 patients shows that both minimally invasive surgical and endoscopic necrosectomy are significantly lower mortality than the traditional open necrosectomy, particularly in high-risk patients. So guidelines now promote a step-up minimal invasive surgical strategy, percutaneous drainage followed by a ward or laparoscopic necrosectomy, where necrosectomy is needed rather than the primary open. So, what are the limitations of endoscopy only stance? So, as Dr. Tahir will agree with me that it's too limited, complication prone, and in many centers, complex necrosectomy is safer in the hand of a surgeon rather than a long-term endoscopic experiment. So, trials and meta-analysis shows no mortality benefits for endoscopic intervention over minimal invasive surgical step-up. Advantage of merely few fistulae, complications, and short hospital stay. These studies are mostly conducted in a high-volume center, and that too where the expertise is available. And they don't eliminate the need of surgery in an extensive laterally placed or disconnected drug disease. Sorry. So, delayed minimal invasive multidisciplinary care is a standard, not reflex open necrosectomy. Endoscopy or percutaneous drainage first wherever feasible. And time of intervention, we all agree that it should be delayed as much as possible, minimum at least 4 weeks. So, however, some set of patients fails to improve, develop complication that has anatomy not amenable to endoscopy, at which point surgical step-up approach becomes indispensable. So I will like to end this talk saying that endoscopy has revolutionized the care, and sorry, and should be the first line where the anatomy and expertise allows. But the safer system is not the endoscopy only; it is the team-based pathway where interventional radiology, advanced endoscopy, and surgeons all are available, and surgery is integrated rather than abundant. So, thank you.
Thank you, Dr. Sahil, for a wonderful talk. May I request Dr. Tahir to kindly come to the dais. Are there any questions or any queries? This is a debate, Professor Bashir Saab.
This necessity and actually network type of computerized is heavily networking other things. This is to the juniors who have seen, we have seen, and we have lost and we have saved with great difficulty some of the patients, maybe in the earliest part. In the terminal part, we, even after necrosectomy, very few of us were lucky to see a living patient. And comorbidity and especially sequelae was very bad. It is theoretically it's very easy to write down, but the question is management of the patient once you know that there is a necrosis and we have to go for necrosectomy. I think at any level it is your instruments cannot be as opening as draining unless a small part of necrosis, because necrosectomy, if you see in general surgery as a surgical intervention, it is actually we are fighting in a fire-ridden area, and whatever is coming in our way, and we are really in trouble. You have shown us a picture which is quite green, and I was very happy, and maybe I was not knowing much. The challenges which you encounter in your endoscopic approach, you have to tell more about that. Please throw some light.
Okay. Thank you, sir. So regarding the instruments, yes, previously there was a limitation in the instruments, but now we have more instruments coming up which can do the necroscopy in a once. Previously, what we used to do, we used to take instruments which were not meant for necrosectomy at front. For example, we used to take senior, we used to take forearm body, which were not meant actually for necroscopy, but we used to make them makeshift instruments for that. But today we have new instruments like endorotor is there, or wind is an instrument which uses water jet, or we have also a new technique where we inject sort of hydrogen peroxide. That is also one of the few newer techniques which is available for necrosectomy. So regarding the instrument part, upgradation has been done, and we are at par with the surgical colleagues in clearing the necrosectomy. Regarding what are the limitations and the complications which we face, or what are the challenges that endoscopists do we face? One challenge was previously was this the location of the collection. Second is the complicated collection. For example, a collection, multiple collection, one in the head, one in the lateral paracolligator. So what we nowadays do, we can manage the one collection, for example, in the head, through the luminal part by placement of a EOS guided lens, and paracolic collection we can take part by the percutaneous endoscopic necrosectomy. And the luminal part we can also do direct endoscopic necrosectomy, where through the lamps we place an endoscope and take out the necrotic material. The other challenges are, I think, are less as compared to surgery. For example, we can take the sicker patient. A patient who has acute severe necrotic pancreatitis in the ICU is not fit for surgery. We can go take the scope there, do pen or do that, which a surgeon or the surgical will be very high risk in that patient. So in that case, I think we have more advantage dealing with the sicker patients, which most of these patients are treating the patient in the ICU, which is not a fit candidate to take to the OR. So I think we have an advantage in that. I don't think the rest of the challenges, I do not see any challenge as of now in our part. Yes, instruments were the challenge previously, but now we have underwater and other instruments which are coming up for the specifically for the purpose of necrosectomy.
Okay, thank you, Dr. Tahir and Dr. Saib, for an excellent debate regarding the use of endoscopy and surgery for pancreatic necrosectomy. Basically, this debate will continue. This answer is not yet there. I think it is complementary. It is not individualized. One size does not fit everything. So it is a complementary, multidisciplinary, and it should be individualized. And of course, you have to find out the balance between the risk and benefit of surgery versus endoscopy. Surgery is definitely more effective, but it comes with a price of more complications like fistula and the bleeding. But the endoscopy is maybe a bit slightly lower effective than surgery, but it comes with a better, outcome in the sense of safety. So that has to be taken into consideration. Otherwise, all the points are well taken here. And because of, we are running short of time, I think we can close this debate. Thank you, both of you. So now, can I invite Dr. Barry, Sams Barry, for his talk on intraperitoneal rupture of hydatid cyst. Dr. Barry, please.
Thank you, Chairperson. This is a topic which is from the resident point of view. Actually, these cases were managed by the residents and just collected and compiled the details. Unfortunately, there is no resident in the audience. So, as we know, the majority of the patients of hydatid disease, they are usually asymptomatic, and most of them are diagnosed when we are doing evaluation for some other disease. Patients may present with, sometimes the patient present with dull aching pain, they will be heaviness in the right hypochondrium, or they may sometimes present as an asymptomatic palpable lump in the right hypochondrium, but some may present only once the complications occur. As per literature, more than 30% patients present with complications such as abscess formation, rupture, or pressure effects. And as far as concerned, the cyst may rupture into the biliary tract, hollow viscera, the pectoral cavity, the pleural cavity. As per literature, the intraoperative rupture is seen in as many as 1 to 4% patients. The intraoperative rupture is usually seen in case of cysts located in the anterior or the inferior the surface of the liver, while the cysts located in the superior and posterior portion usually rupture into the pleural cavity. Patient with intravenous may present several ways. One is diffuse peritonitis, the all features of peritonitis. Then some may present anaphylactic shock, and both these groups of patients need urgent resuscitation, management of the shock, and finally laparotomy. There's a third group of patients which may present with silent abdominal distension. What happens usually because of arterial trauma, there is a small tear in the pericyst through which the fluid and system will leak in the peritoneal cavity, and as the time passes, initially it becomes unnoticed, but as the time passes, the number of cysts and the size of cysts will go over a period of time, and the patient will start feeling abdominal distension. And sometimes it may be so much that he may have difficulty in breathing. He may be respiratory distress. I present 4 cases. As I said, that these are all managed by our residents in the casualty. They present with different clinical features, and all of them are managed successfully. This is a very interesting case, almost managed a decade before. Many of you may believe that it may not be true, but this actually happened. It's a very interesting case. There was a 48-year-old male who presented in the emergency department with a massive abdominal distension. He was in respiratory distress, abdomen was soft, non-tender. The percussion note was dull, abdominal girth was as much as 220 centimeters. You can see the size of the abdomen. He was a chronic alcoholic for last more than 10 years. The representative thought that it's ascites because of chronic liver disease because of alcohol. He thought it's a chronic liver disease, so he thought it's ascites. So he planned to do ascitic tap, but he could not drain any fluid. What he did, he just called the surgical representativity. They thought that the fluid is thick, that is why it is not coming out. So they planned to do a small incision and through that put a small drain, which they did. And she was given abdomen. But as soon as they punctured the peritoneum, small grape-like structures started coming out spontaneously, which were typical of hydrated. So everything got changed. The whole scenario got changed. So what was done? A fresh history was taken from the attendants. So they said that the patient had a history of trauma 3 years before, during which he lost his upper limb because he had to do amputation. And as he was a case of trauma, so he was evaluated at that time. CT abdomen was done, and that had shown a high history of the liver. And he was advised that once he get out of this trauma, he should report to hospital for further measure of the cyst. But unfortunately, he ignored. He did not. He started developing some abdominal distension. He went to clinician. They again told him that he has to get operated. He just ignored again. It happened for 3-4 years. But ultimately, he had a severe respiratory distress and he reported the emergency. So what was done? The patient was taken for immediate laparotomy. A right permission was given. There were hundreds and thousands of the abdominal cavity. They were all retrieved. There was a big cavity in the cyst, which was freely communicated with the abdominal cavity. These cysts were collected in the bucket almost 20 liters. These are the number of cysts. Hundreds and thousands were retrieved from the abdominal cavity, and the weight of these was almost 14 kgs. So as usual, the cyst was managed following the usual protocol. Thorough wash were given. The cavity was examined for any vestibular communication, and ultimately the abdomen was closed after putting fluid drainage, and finally the patient was discharged. And he was on follow for almost 3-4 years, but after that he never reported to the hospital. Then another patient, a child, the 16-year-old, he was 16-year-old who reported again to the emergency with abdominal pain. On asking history, he said that he has been allegedly hit by his brother. On examination, the patient had tenderness all over the body. There was tachycardia, there was hypotension. So a diagnosis of peritonitis is made. Patient was resuscitated and usual protocol was followed. X-ray was done, that was normal. USG abdomen showed a cystic lesion in the left lobe of the liver with some free fluid in the peritoneal cavity. CT was done, we showed a ruptured hydrated cyst in the segment 2 and 3 of the liver, and there was a moderate amount of fluid in the peritoneal cavity. So a diagnosis of ruptured hydrated cyst was made, and the patient had to be taken for emergency laparotomy. This is a CT scan of the patient showing a cyst in the liver, hydrated in the liver. So there was almost 500 ml of fluid in the abdominal cavity and a single large vesicular cyst in the left of the liver. And there was small end of the pericyst, so the fluid was continuously trickling. So as usual, the area was isolated, the cyst cavity was open, all the contents were delivered, and the thorough wash were done, and the disposal was used to sterilize the cavity. This is the intraoperative picture of the same patient. You can see the laminar being delivered. This again a picture of the laminar membrane delivered from the cavity. Then the third case, then finally the drains were put and patient was discharged on a result therapy. He was on follow-up for almost 3 years. Then another patient who was a male around 23 years of age, had a fall from the story on examination. Patient was more stable, but there was small tenderness in the abdomen. A usual protocol was done, X-ray was done, ultrasound was done. Ultrasound showed minimal fluid in the peritoneal cavity, and a cystic lesion in the right of liver, but there was no swollen injury. But since there was a trauma, so he was admitted for observation. But as he was being observed, in the next 3-4 hours, he started developing itching all over the body, and he went into shock. So immediate resuscitation was done. After he was resuscitated, a CT scan was done that showed a ruptured heart cyst in the segment of the liver with a laminated membrane and some amount of fluid in the Morrison's pouch. So this is a patient with a cyst in the segment 8 of the liver. Then the patient was taken for laboratory. So usual protocol, thorough lavage was done, cystectomy was opened, all these contents from the cyst were removed, and ultimately the patient was discharged on albendazole therapy. The fourth patient is a patient, female, 35 years of age, with a sudden onset of cerebral pain in the left upper quadrant. There was no history of trauma, but there was a single episode of non-bilious projectile vomiting. And examination, the patient had a pulse rate of 100 per minute with a BP 110/60. Abdomen was non-disturbed. There was some guarding in the upper abdomen. All the baseline were normal, but radiology showed that there was ruptured cyst in the spleen, 8 by 6 by 5 centimeters, with some free fluid in the pelvis. CT was done. We showed a partially collapsed ruptured spleen cyst with laminated membrane and mild ascites. So as a patient, you can see the cyst in the spleen with laminated membrane. Patient was taken for emergency laparotomy. On the findings were a 10 by 5 centimeter cyst, ruptured cyst involving spleen. The cyst was involving almost more than 2/3 of the spleen. And there was a cystic cavity, had a collapsed laminated membrane, along with almost 7 ml of fluid in the abdominal cavity. This is an intraoperative picture of the patient with a cyst, just 1 minute, sir. The patient underwent splenectomy along with thoracic lavage, drains were put, and ultimately discharged on albendazole therapy. So the conclusion that intraoperative rupture of the heart cyst is a life-threatening complication. It can cause hemodynamic instability and allergic reactions. Heart cyst rupture should be considered in a different drugs in a patient who has sudden onset of abdominal pain and allergic reactions following a blunt trauma. The patient with diffuse peritonitis or anaphylactic shock due to intraoperative rupture of the heart cyst needs urgent resuscitation, malaria with the shock, and immediate laparotomy. In endemic areas, the possibility of slow rupture of the heart cyst into the peritoneal cavity should be considered in patients who present with silent abdominal distension. Follow-up is necessary in these patients. Initially, a monthly follow-up 6 months, for 6 months, followed by 3 months for 1 year, followed by twice a year for at least 5 years. During follow-up, you should undergo your abdominal analyzer. Recurrence has been seen in 2 to 25% patients. If there is no recurrence after 5 years, clinical follow-up can be just terminated. Recurrence can be avoided by putting them on albendazole therapy or therapy such as albendazole, or Jakasicon. Thank you.
Okay, thank you, Dr. Bari, for such an excellent presentation. Like, I have got 2 queries in my mind. First thing is you're doing a laparotomy after the interperitoneal abscess. Do you use any scolecidal agent to irrigate the peritoneal cavity?
Yes, sir,
number
we do
one.
use.
And if you do that, what kind of and what concentrations that is?
Okay, sir, we
And
do
second
use-
thing, what is the medical, treatment as an adjuvant? What is the dose of your albendazole and how long you are going to give it?
Okay, sir. So we always use scolecidal agent. Previously, we were using betadine, but it was staining of the cavity. Nowadays, we use cetrimide, but that is freely available. Although that's again not safe, that can cause a lot of adhesion. The safest is hypertonic saline, but that is usually not available. Number one. Number two, as far as albendazole is concerned, we give a dose of 10 milligram per kg body weight. Now, if it's a planned surgery, we usually put them on pre-operative therapy for at least 3 months, as per WHO course. 28, the WHO this protocol. 28 days course, followed a gap of 2 weeks, then again 28, then again 20, gap of 2, then again 28. And post will follow the same regime. But there is again a confusion as far as this pre-operative is concerned. Some give it only for 2 weeks, some give only for 4 weeks. I said there is no standard protocol.
What about post-op?
Sir.
Post-op, how long
So I
post-op?
give for 3 months. 3 cycles of 28 days.
But it can be given for prolonged periods. Even people have reported
Yes,
this
sir.
albendazole therapy or chemotherapy even for a year or 2.
Exactly, sir. Because I know a patient who I did a lab with this hysterectomy. He had a recurrence. I again started him on the albendazole therapy for 1 year. That absolutely did the patient.
So I have a question. So can we avoid splenectomy in a splenic hydrated?
Sir, it depends upon the location and the size. If it's a small cyst, exophytic cyst, if only one pole, we can easily avoid.
You can only enucleate the.
Yeah, but in this case, it's almost whole spleen was involved. So there was no other option but to remove the suture.
May I put down a comment, please?
Yes, Professor
I did a
Elder.
lot of work on highlighted. We have published a book also. He has been quite close associated with this. The case he showed, first one, I have diagnosed that patient by putting a small knife in the supraumbilical region because nothing was coming out. We got cyst and we shifted him right away because he was in shock. We shifted him right away to the theater. About the post-op albendazole therapy, there is no need of using penziquinone because it is more of a hype rather than avoiding a recurrence. This is literature-based. I'm not saying anything of my own. Usually, if you do a clean surgery, maybe laparoscopic or open, where there is not much spillage and you have used a pre-operative albendazole for a minimum period of 1 month, 4 weeks. It is not.
Here we are
it is not
discussing a
necessary.
patient with peritoneal discrimination, rupture.
I'm going towards that. If you have a cleaner surgery, you know there is minor spill or there may not be any spill. 3 months is the usual course that should be adopted. But if a patient is already having a ruptured cyst and there is a high chance of recurrence because there are areas in the peritoneal cavity which are hidden, which may not be accessed even on open laparotomy sometimes. So with that thing in mind, you have to use post-operative albendazole for 6 months, although there are so many side effects that can occur, which you have to follow the patient nicely and avoid them. Maybe there are different problems, especially with the hematological.
Neutropenia, they develop.
Yes, neutropenia they can develop. They can develop low platelet count. They can develop alopecia. There are so many, and even allergies. Under such circumstances, you have to use a hemogram and an LFT continuously. And there is no need of giving a break. What break was given initially for 1 week. Basically, it is the appearance of jaundice, that is cholecystitis, on clinical ground, that then you can stop the drug.
Okay,
sir,
that
if
is
the-
excellent, sir.
But sir, if the
Yeah.
LFT gets deranged after 4, I think it's better to stop. That is what I have seen many
That
patients.
is why LFT is
When it
monitored.
gets deranged, we stop it. If it
Absolutely,
recovers, we can start.
absolutely.
Okay, everything, good thing has to come to an end. Dr. Bari, thank you for your presentation. Thank you so much.
Thank you, Bari sir. Now I am inviting Dr. Ayaz Ahmed Dhar, who will be speaking on laparoscopic redo hepaticogynostomy in biliary reconstruction through a minimally invasive approach.
Good evening to all of you. I am Dr. Ayaz Ahmed. I am an FNB resident from Sher Kashmir Institute of Medical Sciences, Sora. I will be presenting a video actually on laparoscopic reduced hepaticogynostomy after laparoscopic pancreaticoduodenectomy. A short case history. She is a 30-year-old female with no medical comorbidity. She presented to us as a case of melena. After evaluating upper GI bleed, on endoscopy, there came to be an ulceration at minor papilla. And CECT abnormally showed a 30 mm hypoenhancing lesion at papilla with bilobar IHBR dilatation. Biopsy was done, which showed there is an adenocarcinoma of 11 to 11 mm. MRCP was sought, which shows a double duct sign. After that, the patient was managed with a laparoscopic Whipple, as shown in the film. After 6 months, she came to us with a recurrent episodes of cholangitis, with the features of obstructive jaundice. And a cholangiogram revealed a stricture at the hepaticogynostomy site. Patient was referred to the radiologist. They advised to go for a PDBT in order to drainage her ductal system. After that, she was planned for a region hepaticogynostomy. This is the video of redo hepaticogynostomy. First of all, this is a 3D reconstruction of cholangiogram, which shows a cutoff. These are the port placements. After that, we will do a diagnostic lab. This is expected as there will be a lot of adhesions as the patient has underwent previous laparoscopic pancreaticoduodenectomy. After that, we try to do an adhesiolysis. Because of the difficult anatomy, there will be a lot of dense adhesions. and we will try to do the adsorption and put down the colon. After that, we will try to identify the hepatic hilum. After doing all these adhesions, we will try to identify the hepatic hilum, and we will try to find the rock slime. As we will move on, we will again try to remove the adhesions around the previous hepaticogynostomy site. These are as the video is showing that we are releasing these dense adhesions around the previous hepaticogynostomy. So after following the rock slime, we will reach to the previous hepaticogynostomy site, and we will try to aspirate by the aspiration needle, and which will help us in the identification of the previous hepaticogynostomy or the CSG, proximal CSG. After that, we will transact this. We will remove all the debris which will be inside and all the stones which will be inside. We will remove all those. After that, we will try to identify the PDBD which radiologist people have placed previously. This will help to identify this previous anastomotic site. After that, we will go for the anastomosis using a 3-0 vicryl suture. First of all, we will go for the closure of the posterior layer using a 3-0 vicryl intraplate suture. We may use ICG here to identify properly the CSG, or we may inject the normal saline or ICG via the previous PDBD to identify this site. After doing the posterior layer, this anastomosis, we will go for the anterior layer closure. Using suction, we will try to put away the posterior layer so that it won't come in this anterior layer, as we were discussing previously. After that, after the completion of anastomosis, we will place the drain in subhepatic region. Usually on the third or fourth post-operative day, we will do this intraoperative, fluoroscopy, and we will see the patency of this hepaticogynostomy, radiopaticogynostomy. This is the short case series, not statistically so significant. From last 1 year, we have done 8 radiopaticogynostomy. Out of those, 4 cases were CBD injuries. Post CBD injury, they went under hepaticogynostomy and they presented us as CBD stricture. All of them were managed with laparoscopically. Thank you.
Have you done ICG in all these cases?
Not all the cases, 4 or 5 cases, because previously the ICG was not available actually. So after that, we used this ICG.
Okay, it was a nice demonstration, definitely. But the only concern is hepaticogynostomy redo that is also doing in a laparoscopic way. I'm not against that, of course, but the thing is that it is a redo surgery. Definitely, what was the contraindication of doing, open surgery? Because as a principle of doing an hepaticogynostomy, there are definite principles there. Like the hepaticogynostomy, the size should be more than 2 centimeter, number 1. Number 2, there should be a ductum mucosa. A position has to be there, and the vascularity has to be maintained at any cost. And moreover, the circumferential 360-degree kind of dissection has to be done for a proper ductum mucosa anastomosis that should be watertight with a vascular, edge should be bleeding from the both duct and the enteric side. And moreover, the vascularity, there is a major concern. It is already Whipple's has been done previously. Then you again do some kind of, suboptimal kind of dissections. And it is not, there is a chances that you might injure the, ductal arterial system also there, posteriorly. So all those issues are there. I'm not against it. You must have got away with doing excellent results and other things that is acceptable. But by and large, I think on principles, good tenets of surgical practice and principles, I think it would have warranted an open redo hepatic oxygenation. I'll be really interested in knowing the follow-up this patient. Any other questions from the audience? Anybody wants to make any comment?
Dr. Ayaz, was it a side-to-side anastomosis or end-to-side anastomosis?
It was end to side.
Because the ductal side looked wider.
No,
I thought it probably the side of the duct.
it was the end of the duct and side of the G.
How much was the diameter of the duct?
Diameter, it was 1.5 centimeter.
That is wide, quite wide. It looked as if it was side to side.
Yes.
Mike, please. Mike, please.
Basically, hepatocystectomy has got stenosed. Okay. Now, above that, it is all dilated system. So that is why you have been able to go to the porta and straight away put a needle or that cautery and got the white bile out. That gave you the diagnosis that this is the porta. So there is a side. Now you get the gut and make a side to side anastomosis.
What was the distance from the confluence? Like Bismuth quality, if you say what is the kind of type 1, type 2, what was length of the strictures below the
It
confluence?
was more than 2 centimeter.
More than 2 centimeters. Okay, so you have extended toward the left duct maybe.
Yes.
Okay, fine. It is a excellent demonstration of your laparoscopic skill and capabilities. Definitely, I should congratulate you. But the thing is that as a surgeon, it is a concern for us. That area hepatico now, because it is your only chances of preventing further strictures, further complications, that you have to be very careful. Because every time you do a surgery, every time you are taking up more duct, that will create more fibrosis, more complication, and maybe next time you will not be able to do anything for that matter. So that is the concern. Otherwise, we are not against that. Well done. Any other questions from the audience, please? If there is none, then thank you. Thank you for your nice presentations.
Salim is there. Okay, Dr. Salim is there. So he's a pediatric surgeon, James Jomu. So he will be talking on laparoscopic stapler cystogastrostomy. Cystogastrostomy for post-traumatic pancreatic cirrhosis in a child.
Respected chairperson, my teachers, audience here. First of all, I feel very humbled to be sharing a stage with my guide, my mentor of MS, Professor Nisar Singh. Sir has been my guide when I was a MS student. Thank you so much for teaching me many things. So we are going to share an experience of one of the cases of laparoscopic stapled cystogastrostomy. So the pancreatic cirrhosis is a well-recognized complication following pancreatic trauma in children. Very commonly done now, laparoscopic cystogastrostomy is safe and effective alternative, improved visualization, reduced post-operative pain, shorter hospital stay, better cosmesis. So little advancement is that we have used a stapler in this 9-year-old boy with a persistent upper abdominal pain and fullness 7 weeks after blunt abdominal trauma. Ultrasound and CT confirmed the pancreatic cirrhosis, and the staple cystogastrostomy was fashioned using endoscopic linear stapler to establish a wide communication between the pseudocyst and the stomach. So these are the CT findings before at the first when there was no pseudocyst, and now this is when the pseudocyst appear at 7 weeks. A large pseudocyst we can appreciate on this. So this is endoscopic view with the port sides. We have used 3 ports in this. A large cyst we can appreciate, which is medial to the stomach in the near to the lesser curvature, abutting the stomach. It's a very big cyst. So we tried to aspirate it, but in vain. It was a thick fluid which we could not aspirate using the laparoscopic needle. So this is a hitch stitch I use to hitch the fundus of a stomach. I don't want the stomach to be moving like a mouse inside, and it gives me a little better. It gives me a good. I can take a good care of the stomach with that hitch stitch. So I have used a harmonic stapler to open the anterior wall of the stomach. A small hole using the harmonic stapler, and you can even use the hook cautery forceps. So here I'm opening the anterior wall of the stomach. I have entered into it because there's a giveaway feeling. I would usually open it around 5 to 8 centimeters in length. So after opening the anterior wall of the stomach, I would take another stitch inside to take a stitch in the medial wall of the stomach. That would give me a better visualization of the posterior wall of the stomach, where I am going to operate more and spend more time there. That will give me enough space. Many surgeons, they take on both the sides. I do it on the medial side only. So I just wanted to have a little bit more of visualization. So I would open it a little bit more using this same harmonic stapler, and I can visualize the posterior stomach very well, which I could actually feel a cyst behind it. So the next would be opening up of the posterior wall of the stomach using the same harmonic cautery. So again, I tried to aspirate it because it was a big cyst. I could get a very less space in this small child to maneuver my instruments, but I could not because it was a thick fluid collection inside it that was infected, that I appreciated at the end. So here I can see that I could enter into the cyst. I could see the fluid coming out of it. So now I was lucky to put the aspiration, to aspirate the cyst using the laparoscopic aspiration instrument. So this is the inside view of the cyst. I gave some washes. There were thick flakes inside it. So now I can appreciate both the posterior and the posterior wall. That was a cyst wall, and the posterior wall of the stomach, both in my hand. To have better communication between the two, what we as an advanced procedure in pediatrics did, that we used endo-GS stapler for the first time. So this is endo-GS stapler, using it to open the cyst wide, or keeping the communication wide between the cyst and the stomach. So we can see it here. Again, the washes were given and cleared. The muck inside there was cleared using the washes. Next, I would take a few stitches at the place where I had put the endo-GS stapler, just to be on the safe side. Otherwise, many surgeons might not need it. Just to be on safe side, I took these stitches to close the wall where I had put the endo staplers. So the medial stitch that I had put on the stomach has given me a lot of better visualization. The two stitches I usually put the hitch stitch in the fundus and this medial stitch. So I would close that. This is all I would do in the posterior wall, and would be happy to have a final look before I close the anterior wall of the stomach. So I would put some more stitches on the interior wall. I won't be closing it using the vital suture. These are the stitches in the superior, middle, and the lower part of the anterior wall of the stomach. They give me a better alignment of the stomach before I use the stapler in this again. Children doesn't have that big a stomach where you can sacrifice a lot. So you have to be very, very meticulous with the tissue in children. So this is the stitch which I use to align them together, upper, middle, and the lower part. So once I am happy that the wall I had, there is better alignment of the two sides of the wall, I would again use the endo-JS stapler and use the same thread to align them inside the endo staplers. A couple of staplers used in this. So this was the end, and this is how we closed it. The procedure was completed laparoscopically without any complications. Adequate drainage of the cyst contents were achieved in trough. Post-operative recovery was uneventful. We started feeds on day 3. Child was discharged in a stable condition on day 5. We did keep a drain in. So this was the post-op picture where we could not see a very big scar as we were in open. So we concluded that a laparoscopic staple cystogastrectomy is a safe and effective minimally invasive option for management of large pancreatic pseudocysts in children, providing excellent outcome with faster recovery. Thank you so much.
Yeah, Dr. Salim, thank you for such a beautiful demonstration of your surgical skill
Thank you so much.
in terms of laparoscopic, definitely in pediatrics, definitely. So I'm really, one more thing I just want to mention, that your respect and appreciation for your teacher, that is really heartwarming. And coming to the practical and technical part, in pediatrics, it is a very small space. Do you use what kind of instrument you are using for that? Do you use any specialized, miniaturized instrument, or it is the same adult laparoscopic instruments that you use, number one? And second thing is, was in this particular patient, like endoscopic cystogastrectomy was considered, or what was, why it was not done or considered? Because it is a spectrum, open laparoscopy and endoscopy. Definitely, that is a spectrum of, options that you can, that is, because that you could have considered. So I interested in knowing why it was not considered. Was there any contraindications? And third thing, as you were mentioning, when you are taking some stitches on the stomach anterior wall at the end of your procedures, you are telling that in pediatrics, the stomach size is very small, but still you have taken some kind of bite and you have sacrificed some kind of, stomach wall there after the, that stapler. So it was contradictory for that matter. Any comments?
Yes, stapler should have been avoided. So you should have taken a continuous suture to close the anterior wall of the stomach. You could have saved the stapler cost, and additionally, you could have preserved the the anterior wall of the stomach. There was no need to excise it.
Also, just few more stitches were needed.
So I would come to all the 3 questions.
Okay, please.
So the first one is, so we categorize the children in 3: neonates, small children, infants, or up to, I would say, 5-6 years. Then the pediatric population would be around 18 years. So for this child, we have used 5 mm instruments. For neonates, I operate neonates using 3 mm instruments or 2 mm instruments, even without the ports. I will be presenting it tomorrow, so I will show that. With 3 mm ports, so we have a flexibility of instruments in pediatrics, and I feel very, very lucky to have them with me in my department. So I have that flexibility to use in different age groups. So coming to the second question, this was a very huge cyst. So I don't think we had an option of any other option rather than doing this procedure. And the last one, sir, which you said that we could have, sir, even I was thinking of the same. This child was emaciated, not very well, to be very honest with you. I didn't want to, in children, I tried to be as fast as possible. So the stomach, definitely I would have reduced the some size of stomach, but this would have saved me at least half an hour. It would take me half an hour to take a stitch in this.
No, that is wrong. It will not take you.
That might be
three
wrong,
or
sir. I'm
four
not
stitches,
contradicting,
just I
sir.
think 3-4 minutes.
I'm
So
not-
one thing is, did you consult the endoscopist, GI endoscopist, for managing such a cyst? That would have been less invasive,
So we
isn't
did,
it?
sir,
Endoscopic cystectomy or cystogastrostomy.
sir, we did ask them, sir, because the child had a very huge abdomen. So they categorically said no for any procedure. So that we had left with no option but to do the same.
You have taken 3 stitches on the stomach.
Yes, sir.
Just 3 more were needed.
3 more we needed. Thank you so much, sir.
So time must have not been too much.
He is very rich. He has a lot of endoscopes available.
He is the head of the department. He is the richest person.
Okay, anyway. Okay, thank you, Dr. Salim, for
Thank
your
you so
such a
much.
nice presentation.
Thank you.
Thank you so much.
A new topic has been added in this session is Dr. Amritpal Singh. He will be speaking on road traffic accidents and maxillofacial injuries, causes and prevention.
Respected chairpersons and esteemed surgeons in the gathering. Very good afternoon, very good evening to all of you. I take this opportunity to thank the organizers of this conference to give me an opportunity to be part of this August and Learned gathering. I'm also grateful to the Secretary Jakasi, Dr. Harbinder Singh Bali for his constant motivation and mentorship. I'm also grateful to Dr. Ejaz and Muzaffar sir for his encouragement. I'm indebted to Dr. Varun Dogra and Maria ma'am for preponing my presentation, which was decided in this team because of some important reasons. Anyway, coming to my presentation, I'm Dr. Amrit Pal Singh. I work as assistant professor at postgraduate department of oral and maxillofacial surgery at Indira Gandhi Government Dental College, Jammu. So, road traffic accidents are the major cause of maxillofacial injuries. According to WHO December 2023 data, every year lives of approximately 1.19 million people are cut short as a result of road traffic accidents. Between 20 to 50 million people suffer non-fatal injuries, with many resulting in a disability. In 2023 alone, more than 1,72,000 people lost their lives on Indian roads, which averages 474 deaths each day, or nearly 1 every 3 minutes. So this is the statistics of road traffic deaths per 1 lakh inhabitants in selected countries in the year 2021. And highest number is in Eastern Mediterranean region, countries like Guinea and Libya, and these are in European Union, countries like United Kingdom and Norway. India lies somewhere midway, accounting for 14.6 deaths per lakh population. And as far as global regions are concerned, Southeast Asia accounts for largest number of road traffic accidents in the world, and European Union accounts for least number of road traffic accidents, just emphasizing the importance of infrastructure and law enforcement. So RT statistics in India, this line diagram on the left shows the fatalities and number of accidents, and we have been seeing that this progressive increase in this line diagram. Only dip is in during 2020 COVID times once there were restrictions were enforced and there was lockdown. And facial injuries account for a large number of injuries during these road traffic accidents. And out of the causes, overspeeding is the most common cause of road traffic accidents, followed by drunken driving, and use of mobile also plays an important role. And the category of users affected by road traffic accidents, most commonly two-wheel riders, followed by pedestrians. So in our UT of Jammu and Kashmir, there has been disturbing trend of increasing road traffic accidents, and there have been 4,899 deaths and 40,065 injuries between 2019 and October 30, 2024. This alarming statistics translates to one death approximately every 2 hours, underlining the urgent need for improved road safety measures in our UT. So coming to the maxillofacial region, as we know, it's composed of 14 bones: nasal, lacrimal, inferior nasal concha, and importantly, zygoma, maxilla, and mandible, and we divide it into upper midface, upper midface, lower midface, and the lower face made up of medulla. And we analyzed injuries in 400 patients in our department. And largest number of injuries we saw were 351: external injuries, abrasions, avulsion injuries, and head and neck injuries and face and ENT injuries accounted for 150 and 150. So large number of injuries are concentrated in head and neck and maxillofacial region. And amongst the bones of the maxillofacial region, mandible is most commonly involved, followed by nasal bone. And steering wheel injuries caused by the components of the vehicles, most they can be divided into steering wheel injuries, dashboard, floorboard injuries, seat belt injuries. The largest number of injuries, as you can see in table on the right side, is caused by windscreen, followed by steering wheel. So all types of severity are caused by these components. I will not go into details because of the constraint of the time, but we can have this once there is a engine hits the radiator and bulk engine hits the bulkhead and the passenger is lifted up and smashed against the what we call as dashboard, resulting in injury. Similarly, steering wheel injuries. You can have various types of complex facial fractures, orbital wall fractures. You can have crushed tracheas because of the steering wheel injury. And one more important injury is the whiplash injury, a neck injury caused by head being suddenly and forcefully thrown back and then forward, resulting in hyperextension and hyperflexion, which usually happens in rear end collisions. Once there's rear end collision between the vehicles. So, non-use of safety devices like not wearing helmet and not wearing seat belts, we can see the percentage of people who are not using safety, who are almost 71.3% of the drivers got killed who were not wearing helmets, and 28.7% of the passengers got killed who were not wearing helmets. Similarly, passenger percentage of the individuals who were not wearing seat belts, 50.2% of the drivers they got killed, and 49.8% of the passengers they got killed who were not wearing seat belts. So this table shows the importance of the this safety measures. So safety always says we can see all types of injuries are less in those individuals who have been using seat belts or restraining devices whilst they are traveling. Similarly, the statistics shows that helmets save life, but negligence can still cause harm. If we are wearing helmets, it reduces the risk of head injury by 48 to 60%. Similarly, bicycle riders, there has been alarming increase in USA of 62% if they are not wearing helmets. So use of helmets decreases the traumatic brain injury and improves the overall survival rate of the patients. So has been our experience? So this is a case which we received in emergency wing of the Women Medical College, Jammu, where we provide trauma services 24/7 along in collaboration with the Department of General Surgery. So this is a patient we received after initial stabilization. We took the patient. He was having bilateral midface fracture with nasal bone fracture. Patient was taken and the nasal intubation was done with the help of our anesthesia colleagues. And we fixed the fracture and infraorbital margins using subciliary incisions. And we can appreciate that occlusion has been established. Because in maxillofacial fracture, it is not only the anatomic reduction which is important. Achievement of occlusion is also important. If we don't achieve functional reduction, then patient is not able to have nice achieving. He cannot enjoy his food. Another case, young individual involved in a road traffic accident, having right side mid-face fracture, G2 fracture with left side zygomatic-maxillary complex fracture, and it was associated with a naso-orbitoethmoid fracture. So since nasal intubation could not be done, we went ahead with the submental intubation. With the help of our anesthesia colleagues, we disinfected the mid-face fracture, exposed the fracture site both bilaterally at the zygomatic-maxillary buttons, fixed the fracture, and this is the outcome, 1 month post-operative outcome, and this is the post-operative X-ray showing hardware in place. This is another case, a mandibular fracture, usually high impact injury, and here patient is having fracture of the angle of the mandible. This is the second most common site. Fracture was exposed and again it was fixed, and we were able to achieve good occlusion, and here we have been using 3D plates. Another case, ZMC zygomaticomaxillary complex with mandibular fracture. There was this CT showed this articulation at the FZ suture, at the zygomaticomaxillary buttress, and at the angle. Again, we fixed the fracture both at the FZ suture by giving a lateral eyebrow incision, at the zygomaticomaxillary buttress, and at the angle by using Champy's technique. And this was the post-operative X-ray at the frontozygomatic suture, at the zygomaticomaxillary buttress, and at the angle. Another female we encountered who had suffered an accident while traveling from Koch to Jammu, and she was involved in rear collision. She had a severe injury. She had a symphysis fracture with bilateral condylar fracture. Once we did the CT, we found that this condyle was lateralized and there was decrease in the height of the mandible. Again, this patient, because of bilateral condylar fracture, the height of the mandible decreases and mouth opening gets compromised. And patient cannot be intubated by oral or nasal intubation. We went ahead with some mental intubation. Expose the fracture bilaterally using a retromandibular transparotid approach and fix symphysis with a transoral approach. And then we were able to achieve, this was the pre-operative occlusion and this was the post-operative occlusion. And this is the 1 month follow-up, post-op follow-up. This nice scar, there is no parotid fistula or CLUC in the patient. And this is the post-operative OPG, showing fixation of the both condylar fractures as well as the symphysis fracture. And this CBCT showing the height of the ramus has been restored and condyle is nicely sitting in the fossa. So what is the how to prevention of RTA, which is becoming fast and epidemic in our country? We have to obey speed limits, avoid driving under influence of intoxicants, stay alert, perform regular vehicle maintenance, drive defensively. And then we have prevention, traffic law enforcement, road infrastructure improvement, promote public transportation and restraint use. So these 5 things we have to keep in mind if we want to prevent or decrease this. Fasten seat belt, we should not use mobile, we should not overspeed, and we should be appreciative of the rights of the pedestrians. And we should not tailgate, we should maintain space, and we should always fix a seat belt in the right manner. Then only it will be effective. And similarly, it is important to use helmets for two-wheeler riders, both drivers as well as the pillion riders. So this is a surgical team. The department has been developed by our principal and dean, Dr. Parveen Akhtar Lod. She has developed the department, and we have a 20-bed admission facility also. And recently, we'll be coming up with. In addition to working in the theater, we also engage in community engagement, taking into confidence stakeholders, and this is some of the research. We have published a retrospective study of facial injuries in Jammu region, and another neurological consequences of maxillofacial trauma, and in-depth exploration. Thank you. I take this opportunity to express my gratitude to Department of General Surgery, their faculty, their head of departments, and all the JRs and SRs for their continued support. We're also thankful to Department of Anesthesia and Critical Care for their continued support, and allied departments like ENT, neurosurgery for constant encouragement. Thank you very much.
Thank you, Dr. Singh, for what we appreciate what you are doing. It was an excellent work you are working in the community, definitely, and your presentations. If there is any query from the audiences before we close this session, and for the day, we can close it. Anyone want to make any comments? No one? I think everybody is tired now, and yeah, there is a very important meeting coming up from the association. So I thank you, Dr. Singh, for your excellent presentations. I thank my co-chairs and everyone. Thank you so much.
I request Professor Dr. Nisar Chaudhary sir to kindly felicitate Dr. Tahir Majid sir. I request Professor Dr. Satish Parihar sir to kindly felicitate Dr. Sahil Sandal sir. I request request Professor Dr. N. Kaman sir to kindly felicitate Dr. Shamsul Bari sir. I request Professor Dr. Nisar Chaudhary sir to kindly felicitate Dr. Ayaz Ahmed Bhatt sir. I request Professor Dr. N. Kaman sir to kindly felicitate Dr. Salim Naski sir. I request Professor Dr. Satish Parihar sir to kindly felicitate Dr. Amrit Pal Singh sir.
I request Dr. Rajni Bhardwaj ma'am to please come on the stage and felicitate our chairpersons for the session. Dr. Satish Parihar. On behalf of the organizing committee, it is my great pleasure to cordially invite you all to the gala dinner at 8 p.m. at Vrindavan Guest House. There is a general body meeting in Hall 2 outside the auditorium at 6 p.m. Thank you. With this, we conclude day 2 of the conference.